All right. Hello and welcome, everyone. My name is Meredith Shanda. I am the COO for MAVEN Project, and I want to thank you all for joining us today. And a special thank you to our friends at Charles River Community Health for hosting today's session on antibiotic stewardship in the outpatient setting with Dr. Saadia Griffith-Howard. For those of you who have not met Dr. Griffith-Howard before, she has held multiple clinical and administrative positions until her recent retirement from formal clinical practice. As an infectious disease physician, she has over 30 years of experience providing both direct patient care in the ambulatory setting as well as the inpatient setting. She has participated in infection control and pharmacy and therapeutics committees, as well as emergency and disaster management planning related to organizational response to both anthrax and COVID-19. Dr. Griffith Howard has held various roles over the years, and she recently completed a 10-year appointment as the Regional Medical Director of Patient Safety, Risk Management, and Medical Legal Affairs for her former medical group. She also has completed training as a patient safety executive at the Institute for Healthcare Improvement, Risk Management Training at the Academy of the American Society of Healthcare Risk Managers. And she's also, in her spare time, a Team Steps Master Trainer. I don't know where she finds the time to do this all. But thank you, Dr. Griffith Howard, for sharing your expertise with us today. And with that, I will turn it over to you.
Hey, thank you for that kind introduction. I always say, who is she talking about? Okay. But thank you everyone for joining us this morning. And my topic today is going to be antibiotic stewardship in the outpatient setting. I'm very happy to speak with you. I'm going to start just by saying I really probably should have titled this antimicrobial stewardship in the outpatient setting because everything that I talk about also it could apply to fungal and viral treatments, but today we're going to focus on our antibacterial treatments. So with that said, let's go ahead and get started. And I'm just going to click through these disclosure slides, excuse me. I have nothing to disclose. So let's go ahead and get started. I'm just going to adjust the picture here for me. Okay. So when I first did this talk, this is the second time I'm doing it. It coincided very nicely with Antibiotic Awareness Week. So all of the graphics that you're going to see in my presentation, I've taken from the CDC's site about antibiotic awareness. So if you find after I talk that you might want to display some of these in your clinics, it should not be a problem. So for today, we're going to define the principles and the goals of antibiotic stewardship. We're going to spend a few seconds talking about clinician concerns regarding antibiotic stewardship. We'll spend some time on common clinical scenarios, and I did receive one or two from your clinic that you wanted me to touch on. And most importantly, I'd like to end by learning what tools are available to aid in proper antibiotic administration, because after you're done listening to me, life goes on and you do want to stay up to date and have quick ways to find the information that you need. So what's our roadmap to get through all this? We'll start by the definition of antibiotic stewardship. I have a slide that I call a reality check for clinic because I know it's easy for me to sit here and tell you what to do, but sometimes it's harder to when you're on the front line facing the patients to follow all these techniques. As I said, we'll talk about tools and general principles, our clinical scenarios, and I have several slides on resources and references. And I always say we'll get there, but maybe not totally in this order. So let's start, excuse me, let's start with antibiotic stewardship definition and goals. So antibiotic stewardship is defined as the systematic measurement and coordinated interventions to promote the optimal use of antimicrobial agents. These programs are very formalized, certainly in the inpatient setting in our hospitals and our long-term care facilities. In outpatient clinics that are formally associated with some of the hospitals, there are also requirements. But for the clinics like you are, this is just going to be an educational choice. I don't know if you have any measurements that you are being followed for. But basically, it all boils down to using the proper antibiotic, so it's your choice, using the proper dose, giving it via the proper route, and most important, for the proper duration of time. So those are the principles that go into antibiotic stewardship. And why do we do this? What is our goal? Of course, our goal is to optimize clinical outcomes while managing unintended consequences. And what are those unintended consequences? Of course, toxicity, of course, comes to mind. But you also have selection of pathogenic organisms and more resistant organisms, which are always a concern in our present environment. And all of this boils down to the fact that we really want to optimize resource utilization. We want to extend the life of antibiotics. And by optimizing resource utilization, hopefully we will have dollars and cents to invest in other parts of our medical needs. So what is the scope of the problem? It's actually very good that we talk about this in the outpatient setting because the majority of antimicrobial prescriptions that are used in the United States occur in the outpatient setting. And per the CDC, you see 211 million courses of antimicrobials are prescribed in the outpatient setting. And there's estimates by the CDC that up to 30% of the antibiotics prescribed in clinics are unnecessary. So that's a huge amount. And then on top of that, many more when they are used are suboptimal because it's not the right dose for the patient or other things that are not taken into consideration. So it's very important that we get a handle on this and we can have a big impact. So now let's talk about reality. So it's easy for me to sit here and say, I want you to do a good job, but there are a lot of things that go into really having an active antimicrobial sensitivity in your clinic. So of course, most obviously, we have to have a clinician provider commitment required to say, I'm going to change my behavior and my practice in regards to the antimicrobials I use. Providers' knowledge gaps, we're going to address some of those today and leave you with the tools to always be able to address this, hopefully real time. But we get down to patient expectations. The reality is you are dealing with patient satisfaction surveys. Everybody wants to do a good job. And when you have a patient who comes in expecting antibiotics, it's a long discussion to try to tell them this is not the best course for you. There's concerns on the clinician sides with watchful waiting. We know that maybe we don't have to give somebody an antibiotic, but we have to be assured that they will come back if they get worse. What will happen if they worsen and become sick and end up being hospitalized because I didn't give them that antibiotic when I saw them in the clinic? So that's a true concern. And then depending on your clinic population, is it transient? Is it somebody who you can see again? I already touched about patient satisfaction surveys. We have to be good communicators, of course. Then two other options at the bottom. Do you have real-time support for antimicrobial decision making? Of course, I was part of a large group, so my primary care providers that I worked with could, send secure texts. They could page me to get some real-time support for what they wanted to do with antimicrobials. And in some places, there's an an antibiotic approval process which, of course, is designed to limit use of certain antibiotics. But again, all of these things can take time in a busy clinic. And so I wanted to recognize that fact for you as we continue on with this discussion. So here's a few interesting studies that I found that I wanted to touch on before we get into our various clinical scenarios. So the first one I've titled, It Can Be Done. So this study actually looked at the VA administration, and they looked at the amount of antibiotics prescribed by different providers. So there are some providers who know how to get it done. So they found that the top 10% of providers who prescribe the most antibiotics did so for 95% of their acute respiratory infection visits, while the lowest providers did so for only 40% of their acute respiratory illness visits. So there is a difference. There are some doctors who are figuring out how to do it. And, one of the things you might do, depending on your commitment to this, is even have a discussion among yourselves as to how do you do it? How do you let somebody leave without an antibiotic for acute sinusitis? What's your technique? So those kind of discussions can be helpful. The other thing for us as clinicians, is that assumptions can be wrong. The CDC also did a study where they looked at the difference in expectations between providers and patients. And they thought that 54% of providers believed that their patients wanted a prescription for antimicrobials during a visit for cough and cold, while only 26% of patients wanted a prescription. Now, expectations can vary by racial groups and cultures, but this study definitely suggested that as clinicians, we may be wrong about the expectations of our patients, and perhaps we should take the time to have a discussion and tell them, you don't need an antibiotic for that cold. So I thought that those were two interesting things to share. And finally, another study here, and I titled this slide, "Can Signage Help You?" And this was an interesting study. It was called the Commitment Letter Study. And what they did in this study is they put up poster size commitment letters with the physician signatures and photographs. And the physicians were making a commitment to avoid inappropriate antibiotic prescribing for acute respiratory infections. And just by use of this letter, and they tracked all of the physicians, they saw that there was basically almost a 20% drop in inappropriate antibiotics prescribing over the 12 weeks of the study. Now, what was interesting of this is the commitment letter really its effect, they measured the effect on physician behavior change. So it wasn't necessarily looking at the patient's behavior, but that physicians, because you put it out there, I'm committed to using antibiotics appropriately, that it made you as a physician really want to stand up to your principles. So it was really interesting. Now, of course, a patient sitting in a room looking at that letter may change their mind and not ask a physician for antibiotics. But again, these were sort of interesting. So I think as I leave this part of the presentation, my take home message is that it can be done. There are some doctors among you or some providers among you, excuse me, who are probably already very good at this. It does take some effort, but I think it's worth the effort. Okay, so finally, again, additional thoughts before we go to our clinical scenario review. What are things that can help you to be a better antibiotic prescriber? Certainly for individual patients, whenever you have old cultures available, especially your urinary tract infection kind of patients, you do want to check that. I'll ask you if your clinic has access to a local antibiogram. And by this, I mean every lab that you use, and you probably outsource to a lab, has a pathologist there who can give you a list of the common bacteria that they're getting from your clinic or from your clinical area, and their antibiotic susceptibilities. And having this information on hand is very, very helpful when you have to use and treat somebody empirically, especially for something like urinary tract infections and perhaps for pulmonary infections. So it's worth asking if you have somebody who can be in contact with your lab, with your reference lab, it is worth asking to see if you can have that. Of course, whenever we talk about antibiotics, it's important that, again, the proper dosing for size, renal, and hepatic function. Again, I always laugh. I'm sure many people have had the experience. We go through the whole obsession of calculating the right dose of aminoglycosides for our patient. And then we say, well, how much do you think they weigh? Okay, so we don't do the simple thing of just getting the weight so we can give them the right dose. Always, could your patient be pregnant? Is your patient immunocompromised? Of course. What other comorbidities do they have? Treatment guidelines to help with decision making. The answer is for a lot of these infections there are, and I'll show you where you can find them. We always want to worry about adverse effects and interactions. And then in my risk management role, I always say document discussions. Now, certainly you don't have to document every single adverse effect of an antibiotic. And or if you tell somebody watchful waiting, but for important side effects, knowing your patient. So for instance, let's say you have a young student athlete who you need to use a fluoroquinolone on, and you know that there could be problems with tendonitis. that's something that I'd write down in the chart. I had a situation with physicians relying on the education that the pharmacist gives you, those little education sheets that may talk about various antibiotic side effects. But if you can't prove that the patient got it, that's really not going to help you if you get into a risk management kind of situation. So again, judicious documentation of important discussions will be helpful for you going forward. Okay, so let's start to talk about some common outpatient scenarios as we transition to the second part of our presentation. And I'm going to spend some time on acute upper respiratory syndromes, and you'll see the four that we will discuss. I'm going to talk about urinary tract infections, mostly the common urinary tract infections there. We'll talk about skin and soft tissue, saying a few words about cellulitis and our diabetic foot infections. And as I say, I have one slide on C. diff because, of course, we could do a whole session on any of these topics, really. But we're going to at least try to touch base and give you some guidance on each one of these that I've outlined. Okay, so let's start with acute rhinosinusitis. I think I'm going to work from the top down. We'll end up in the lungs as we leave this situation. So first of all, we call it rhinosinusitis officially because it always usually involves your sinuses and your nasal passages as well as your sinus. And uncomplicated, so I'm just talking about your run-of-the-mill patient, maybe not your immunocompromised patient, but a patient who comes in with a diagnosis that I have purulent, I'm sorry, a complaint that I've had purulent discharge from my nose and I have congestion and facial pain, and doc, I would like to have an antibiotic. So several of the clinical features of this syndrome is that you do have purulent discharge and it can be present for up to 4 weeks. Okay, so a lot of us want sinusitis or sinus infections or sinus symptoms, excuse me, to be gone in 5 to 7 days, but you see this can really last for quite some time. As I said, it involves inflammation of the nasal cavity and the paranasal sinuses, and it's mostly a viral infection. Okay, you see that I've highlighted in the bottom that bacterial infection occurs in only 0.5 to 2% of episodes. And the other thing to take away from this slide is that a purulent discharge does not mean that it is bacterial. So that's going to be one of my take-home messages from the respiratory part of this presentation, is that just because a discharge from your nose is purulent, it does not mean that it is a bacterial infection. It could certainly be a viral infection, and we don't treat most viruses. So what should we do when a patient comes to us with just acute rhinosinusitis? It's really symptomatic treatment and supportive care as your initial approach. Pain medicines, antipyretics, saline irrigation, and intranasal glucocorticoids are the way to go. And you really want to observe someone for at least 7 days. And most people, even though I said it can last up to 4 weeks, it typically resolves in 7 to 10 days. So that patient who comes to see you 2 to 3 days, maybe even 5 days into their symptoms, you do want to try to put them off and not necessarily give them antibiotics. Again, as we talked about, watchful waiting. Can they come back? That's something you can do. Another thing I didn't touch on in the slides, some people go ahead, if you know return is a problem and you trust your patients, you could give them antibiotic prescription and say, don't fill this unless, next week you're still having symptoms, that kind of thing. Now, let's talk about bacterial sinusitis. So sometimes it can be a bacterial rhinosinusitis. But again, this is a clinical diagnosis and it's requiring that symptoms be present for over 10 days. Okay, so we said at least we're going to let them go for 7 to 10 days without antibiotics. Or if they had an acute sinusitis that got better and then suddenly worsened, you might think about a bacterial infection. and it's treated with antibiotics, of course. If you think that somebody has an acute bacterial rhinosinusitis, but when they've done studies about this, they do have a slightly shorter course of illness, but they have much more adverse effects once you start using antibiotics, of course, right? So people have nauseousness, people have vomiting, a little diarrhea, those kinds of things. Of course, allergic reactions that can happen. So again, you want to be judicious in who you use antibiotics with. I've listed for here the organisms that you usually would see: Strep pneumo, Haemophilus, Moraxella, not too much Staph aureus, and Strep pyogenes. So those are the usual organisms, the ones that we usually find in the upper respiratory area. And still, you can still do watchful waiting here with the acute bacterial rhinosinusitis. So again, depending on who your patient is, how they feel about taking antibiotics, what other medical problems they have, even in somebody who's now been symptomatic for 7 to 10 days and you're saying, well, maybe it is bacterial, you can still do watchful waiting. But if at that point you want to give antibiotic therapy, you would give the antibiotics that would cover the organisms that I just talked about, amoxicillin with or without clavulanic acid. But again, you see that you can treat them as shortly as 5 to 10 days. Okay. So you don't have to give 10 to 14 days of antibiotics right off the bat. There's still, as I said, you could still observe them first. Then if their acute bacterial rhinosinusitis doesn't improve, then again, you would still go to the same antibiotics, either amoxicillin or amoxicillin clavulanate, to be treated after that fact. And I put some alternatives here, depending on your preference, that would also be acceptable. So now let's keep going down and let's now start to talk about acute bronchitis. So interesting things about acute bronchitis. First of all, if you look at the slide to the right, you'll see that the incidence of acute bronchitis coincides with the incidence of respiratory viruses in the United States. And it definitely has a seasonal occurrence, going along with, of course, the times when we are mostly inside. And influenza virus, respiratory syncytial virus are common viruses to be involved with this syndrome of acute bronchitis. And the slides don't have COVID in there, but I think today, of course, we would have to think about COVID also. So an amazing amount of people come in for acute bronchitis. 10% of ambulatory care visits in the USA are for acute bronchitis. And this is a self-limited inflammation of our large airways resulting in cough. And again, this cough can last for 2 to 3 weeks. So again, I guess as clinicians, we have to continue to be mindful that a cough can last for a long time. And we see that the etiology is usually viral. It's a clinical diagnosis. You're going to be looking for that history of the patient telling you, okay, I've been coughing, doc, but you don't see the evidence of pneumonia, the high fever. You don't hear anything, rales and rhonchi, etc., on your chest examination. And in the absence of chronic lung disease, which we're going to talk about, antibiotics are not recommended for acute bronchitis. When they have done studies to look at it, antibiotics reduce the cough or the illness by a half a day only, and place the patients, of course, at risk for adverse effects. So multiple studies have shown that there's really no significant benefit of using antibiotics if you think that someone has acute bronchitis. Now, again, we said that these are mostly viral, and here's a list of the viruses that have been associated with acute bronchitis. And the treatment really for acute bronchitis are inhalers. So bronchodilator therapy is what you want to do with a lot of education. We have here, you want to align your expectations. So you really have to let your patient know this is going to be 3 to 4 histories of cough. If you don't, I'm sorry, 3 or 4 weeks of cough, I'm sorry. You want to make a follow-up plan with your patient. You offer the symptomatic treatment. And as I said, bronchodilators are good. And you can review potential antibiotic adverse effects if you want to try to steer your patient away from antibiotics. But sometimes that can be a double-edged sword, because I've had situations where I talked so nice and strongly against antibiotics, and then you get to a situation where you have to give the patient an antibiotic. They'll say, well, doc, didn't you tell me if I took this antibiotic, I might have this terrible allergic reaction? So you always have to be careful when you use that strategy. But what I do want to focus on right now is really prevention and vaccination before the season is the way to go to help impact acute bronchitis. We have influenza vaccines, we have COVID-19 vaccines, now we have our respiratory syncytial virus vaccines, especially for our patients over 60, so you definitely want to use that. And you have your various diphtheria, tetanus and pertussis preparations, again, because you know that pertussis can be one of the etiologies. So you definitely want to make sure in your patients, if you can do that before bronchitis season or even during it, it's really a good thing to do. Another thing that is sometimes recommended is start to call acute bronchitis a chest cold, because people have a tendency to think about colds in a different way and not think so much that I need an antibiotic to address this. Now we come on to chronic obstructive pulmonary disease exacerbation. So now these are your patients, different than your necessarily your bronchitis patients who may otherwise be healthy and have no type of lung disease. Your COPD patients certainly have carrying a diagnosis of COPD, and now you need to understand, do they need antibiotics for their exacerbation? So first of all, the definition of a COPD exacerbation, a respiratory event characterized by dyspnea and or cough that worsens again for up to 14 days, which may be accompanied by tachypnea, tachycardia, and is associated with increased local and systemic inflammation. It can happen from airway infection, which is about 70% of the causes, but it can also be from pollution. It can be from other insults to the airway. So again, this is from the Global Association for Lung Disease, so obstructive lung disease. So that's a working group GOLD is their acronym. So again, even though 70% of the time it is an infection, it's not an infection 100% of the time. And when you're approaching somebody with COPD, trying to decide, is this someone that I need to give antibiotics for? It really is a situation of how you characterize their exacerbation. Is this a mild, moderate, or severe exacerbation of COPD? So the mild, and what we would call a mild exacerbation, which is the one category where you're going to think, well, maybe I can get away without using antibiotics. You don't have any resting dyspnea or respiratory distress, and the patient tells you, yes, I've been coughing more, doc, but I can still get through the day. I'm still doing everything that I normally do. Clinical assessment, the pulse ox has to be 92% or greater, or less than a 3% change for baseline, because we know our COPD patients may not have a normal pulse ox. You have a low heart rate, you have a low respiratory rate. And so in a mild case, you can consider holding antibiotics initially. Again, you have these three, what they call cardinal symptoms, and there's a great trial by Antonison trial that I have listed at the bottom of the slide, which looked at how many of these three cardinal symptoms, the dyspnea, sputum volume and or viscosity, and increase in sputum purulence, that the patients had in their study. If they had only one cardinal symptom, no hospitalization or vent support was usually needed at any point during that particular exacerbation. And in those patients, you may consider holding their antibiotics. So in this particular trial that I'm referencing, they looked at 362 COPD exacerbations over a 3.5-year period. Now, they did find that antibiotic therapy was associated with clinical improvement overall, 68 versus 55%, because remember, again, not everything is bacterial. However, the greatest effect was observed in patients who had 3 of these cardinal signs. So in those patients who had 1 cardinal sign, which would go along with your mild patient, the benefit was the least evident. So it was 75 versus 70%. So again, my take home from this is if I have someone who has only 1 sign of these, one of the 3 cardinal signs, and I would characterize as a mild patient, I can consider holding antibiotics. Again, with close follow-up, this is the kind of patient who I would want to say, if you start to get worse, if I need to hear from you. So as we said, viral cause of COPD is about 50-50. You have a bacterial cause in about 50%, and you have viral cause in about 44%. And remember, I said the other COPD exacerbations can be from non-infectious and non-infectious causes. You can have PEs, these are usually sick patients. You can have an MI, other kinds of things. So, but you do have bacteria present. So if you're going to use antibiotics, you're thinking about Haemophilus influenza, Moraxella, strep pneumonia. Pseudomonas is a low percent, only 1 to 13%, and I wouldn't necessarily be concerned about Pseudomonas unless somebody has had Pseudomonas before. And you can give empiric antibiotics. Azithromycin, clarithromycin, I don't have to read them all. You see them on the slides, and the slides will be available to you. But I think the other important as part of this is, remember, part of antimicrobial stewardship is duration. So we're only talking about 3 to 5 days of antibiotics. So again, we're not talking about long treatments of antibiotics. And remember, symptoms can persist even though we have finished our antibiotic treatment. So finally, let's go all the way down into our lungs proper, and we're going to get to community-acquired pneumonia. Now, you've had all of these patients with various upper respiratory infections that I've talked about or symptoms. And now, when are we going to think that this is more serious, that this is pneumonia? We're going to look at our vital signs, of course. If you have abnormal vital signs, heart rate, respiratory rate, and temps over 100.5, as you see. Our chest examination showing rales, egophony, fremitus, they're going to tell us something's going on. We will always keep in the back of our mind, of course, that I have an elderly patient or I have an immunocompromised patient. So the signs and symptoms may not be perfect. So maybe I do want to lean a little bit towards a chest x-ray in this person. And again, we have this caveat that purulent sputum is a poor predictor of bacterial infection. Again, it could be a viral pneumonia. So we can't necessarily rely on purulent sputum. Also, the diagnosis, of course, for pneumonia is based on our chest x-ray finding. And if we have a negative chest x-ray, but we have a high level of suspicion, especially in an immunocompromised patient, then of course, depending on the resources in your clinic, you can consider getting them a chest CT. So mild ambulatory pneumonia, community-acquired pneumonia, we usually don't end up doing any kind of testing. We don't really have the ability to really get, in the clinic situation, often really good specimens. But of course, during this time, you always should consider COVID-19. We're still in a situation where people are dying, and we do have treatments. And again, depending on the time of year, you might want to do influenza testing if it would change your management. So I think both of these are worth doing, especially if you have someone who's immunocompromised, because we do have treatment for both of these. Now, in somebody who you want to treat as an outpatient, you do want to use one of the clinical prediction tools for mortality and admission to an ICU. And there are 2 that are available, the Pneumonia Severity Index, which is a better predictor actually now considered than the older Curve 65 tool. And both of these tools, there's a lot of calculators, and in my resources that I would give you, you're going to put in information about age or comorbidities, certain lab tests, and it's going to stratify your patients for you. And the patients with no comorbidities, and lower values usually can be treated as an outpatient. So your common organisms, if you have no comorbidities, again, you have your strep pneumonia, but for the first time, we see atypical organisms coming to play. Chlamydia pneumoniae, Chlamydia psittaci, Legionella mycoplasma, Coxiella, as well as multiple viral etiologies. And when we have comorbidities, that's when you start to see other things such as strep pneumonia, Moraxella, anaerobe, certainly if people have alcoholism or bad dentition, and Staph aureus, depending on previous history. So take home again is if they have no significant comorbidities, you're going to use amoxicillin or doxycycline. And again, please note, we're talking about only 5 to 7 days of treatment. When I started my career many moons ago, we were talking about 14 days, usually 10 to 14 days of antibiotic treatments for pneumonia, but it's much shorter. And if they have comorbidities, it's still pretty much 5 to 7 days at the most to treat for pneumonia. So again, community-acquired pneumonia, those are your choices, but the take-home message is for a shorter period of time than some of us may have been trained for. So before I leave the respiratory illness section, because this is something that we see a lot, let us just summarize. So my take-homes would be that in the cases of sinusitis, acute bronchitis, the mild COP designation with one cardinal sign, immediate antibiotics does not have to be your default position. So you can consider holding antibiotics in those patients, patient education, following up, delayed antibiotic. If you feel you want to leave them, let them leave the clinic with a prescription to say, don't fill it for a few days. Purulent sputum is not a helpful identifier of bacterial illness. We can see that also in viral illness. We're always going to keep in mind that our presentations can be typical with our elderly and immunocompromised patients. Again, we always individualize recommendations and we use vaccinations for prevention. So we're always thinking about getting those in. All righty, let's go to urinary tract infections. And again, as I said, all of these graphics are from the CDC. So if you wanted to put some up in your clinic, they're available to you. So my big take home, I think, for the urinary tract infections here is that the first thing is I want us all to be familiar and comfortable with understanding that there is this entity of asymptomatic bacteria, and we can get fooled into giving somebody antibiotics if we are not aware of this. So definition, isolation of a specified quantitative amount of bacteria can be 10 to the fifth in an individual without symptoms of a UTI. So that means they have no dysuria, they don't have urinary frequency, urgency, they don't have flank pain, they don't have CVAT. And you get a urine culture and you find these bacteria, you find white cells, and you want to treat them with an antibiotic. And a big take home, it's sort of the equivalent of the purulent sputum, doesn't mean a bacterial infection. I would say pyuria, which is defined as greater than or equal to 10 white blood cells per milliliter of uncentrifuged urine, can occur with symptomatic bacteria and does not indicate the need for treatment. This entity has a benign natural history. They studied over 600 females with diabetes and asymptomatic bacteria, for over 6 years, and there was no correlation with decrease in renal function, okay? And they looked at people, and the incidence of asymptomatic bacteria in women increases with time, so that by the time women are over 80, over 20 to 30% of them have asymptomatic bacteria. And by the time men are 75, 15 to 20% will have asymptomatic bacteria. So this is really something that we need to be aware of. The best recommendation is don't do a culture you will not treat. Again, I know it's easy for me to say. When you have the patients coming in with failure to thrive and you do a urine culture that's going to end up giving you something that you need to treat, try not to do the culture. The only subset of patients where there is some data is the neurogenic bladder in your spinal cord patients, where their UTIs can present sort of as fever, failure to thrive, that kind of thing. But for your average patient, you really want to avoid doing that urine culture as the first line of your antimicrobial stewardship. Now, when we talk about the treatment of acute uncomplicated UTIs for both men and women, this is where your local antibiogram is really, really helpful. Our IDSA guidelines are being updated, but we know that the etiology of this is usually Enterobacteriaceae, with most of the acute uncomplicated UTIs in females being from E. coli. And your antibiotic therapy, first line Bactrim DS, 1 BID, again, just for 3 days, not longer treatment. That caveat if you have less than 20% E. coli resistance in your population. So that's why knowing that local antibiogram is helpful. You can also use nitrofurantoin, 100 milligrams POBID for 5 days. New data from the Society of Geriatrics. We know that we've been sort of put off from using nitrofurantoin in older adults, but their new data suggests that if patients have a creatinine clearance of greater than 30, their guidelines say you can still use nitrofurantoin. So a big part of the concern about using in older adults was because most people have a creatinine clearance that would be less than 60 in that age group, or many, I shouldn't say everyone, but many may. So again, Bactrim and nitrofurantoin are your two go-to antibiotics, although there are a lot of alternatives here for you to use. Fosfomycin, which is the first one that I've listed, that is expensive, but again, it is an oral treatment, and I will touch base on that when you have your extended beta-lactam organisms. Is your patient sexually active? If she is sexually active, then you do want to consider doing STD testing, because of course, if you have chlamydia, et cetera, causing some symptoms, they're not going to be treated by either of these treatments that we said. Empiric treatment of a UTI for a male, again, the etiology is the same. Most of them are E. coli for acute urinary tract infections. You see the Bactrim and the nitrofurantoin, a little bit longer for men. They're saying 7 days. And you can use Cipro and levofloxacin also, again, for men. And here you have your alternatives again. Sexually active, consider STD testing. Now, most time for men, you are not treating for a prostate infection when you think somebody has a urinary tract infection, unless they have symptoms of obstruction. So if this is accompanied by symptoms of obstruction, difficulty passing urine, et cetera, then you would consider that you might need to treat for prostatitis. Your treatment would then be extended for 10 to 14 days, and you would tend towards using Bactrim or quinolone because those have prostatic penetration. Okay, so those would be the times when you would think about that for your male patients. So some additional considerations as we talk about our urinary tract infection. We know that E. coli resistance is increasing. As I said, that local antibiogram will be helpful to you. Nitrofurantoin and fosfomycin remain active for most of our multiple drug-resistant E. coli UTIs. And again, fosfomycin is not necessarily recommended. It's oral medication. It's not usually recommended for pyelonephritis. So again, this would be lower urinary tract infections. ESBL organisms, which we're seeing a lot more of producing E. coli and Klebsiella, are often still susceptible to fosfomycin as an oral agent. One of the things you might want to do with your antibiogram or with a particular culture on your patients, you can ask your lab to do that testing. I'm sure they don't normally report it out, but again, if you call the lab, they will usually give you that additional information. And of course, IV ertapenem as a treatment, because it is once a day, is usually what's helpful. I used to get calls, I should say, that people don't understand that if something is an ESBL, that means no matter what comes out on your antibiotic sensitivities, it is not sensitive to penicillins. It is not sensitive to cephalosporins. Occasionally you'll get a cephalosporin and it'll look like it's sensitive to it, but it really is not. So you don't want to use anything in those two lines of antibiotics. There are often additional drug resistant finding in your ESBL producing organisms, so that makes it more complicated. And if you treat empirically for a urinary tract infection, because we often don't do a culture, especially a woman who comes in with an uncomplicated UTI, but that treatment fails, then you do want to perform a culture. And based on what that finding is, you may treat for 10 to 14 days in that situation. All right, so we're rounding the quarter almost to the end and hopefully time for questions. Cellulitis and erysipelas of the lower extremity. So, it's hard to demarcate a lot of times between this. In both of these situations, erysipelas and cellulitis, you're going to have erythema, edema, and warmth. You think a little bit more of erysipelas because you're going to have the bright red skin with a clearly demarcated raised borders. And with cellulitis, it's usually a little bit deeper, so you have that indistinctive border because it's more in the connective tissues. Erysipelas is usually beta hemolytic streptococcal infection. Cellulitis may be strep, but it also may be Staphylococcus aureus. But overall, most of these kinds of infections are strep, but exceptions to both exist. You are going to be concerned for methicillin-resistant Staph aureus in patients who are IV drug users, especially have an infection surrounding an injection site, prior history of a positive nasal culture for MRSA, or if the patient has had an abscess as part of their infection or recently had an abscess. Now, we often try to treat with oral antibiotics. And so here are the regimens. Again, as I said, strep and MSSA, you can use dicloxacillin, cephalexin, etc. A lot of times with these cellulitis and erysipelas, they can be fast moving, especially strep. So these are the kind of patients who I like to draw a line around their area of erythema on their leg. And I tell them your really improvement the first day is that it just doesn't get any bigger. So a lot of times patients and clinicians really want things to go start to recede right away. But basically, if you stay the same in your first 24 hours of antibiotics, that's good. With some of these infections, if you can give 1 or 2 doses IV to begin the treatment and then transition to oral, that might be that is helpful and sometimes really gets a handle on things for you. MRSA concern, you're going to use Bactrim, but again, it's not 1 Bactrim DS twice a day. It's actually 2 Bactrim DS twice a day to make sure that you reach that appropriate level to treat staph. You have other drugs, linezolid, clindamycin, doxycycline. Again, if you have the opportunity sometimes to give an IV dose of Venco or daptomycin to start the treatment and then go over to something orally, that's a possibility too. For cellulitis and erysipelas of the lower extremity, you're going to treat for 7 to 10 days. Although some doctors treat for a shorter period of time, they say until the patient is afebrile for 3 to 5 days. But I usually do 7 to 10 days for these kinds of infection. Now, the big caveat here, or the reminder, is that a lot of the patients who get this infection have pretty impressive stasis dermatitis, and that can be associated with skin color changes. And I've had referrals because, oh, this patient's cellulitis is just not getting better. I've had them on antibiotics for 2 or 3 weeks, and the clinician has been fooled because of the color changes that you see. So remember, you give your antibiotic treatment. Is my patient otherwise better? They're afebrile, their white count is good, they're feeling better, looking better, the skin is cool. That color change may take weeks to months to improve, if it improves at all. So again, don't be fooled and prolonged antibiotics because of that. Alrighty, diabetic foot infections. Let's say a few things about this. So again, diabetic foot infections, we know that risk factors for these kind of illnesses are neuropathy, peripheral vascular disease, poor glycemic control, all things that contribute to it, and things that need to be addressed to help for healing, especially the glycemic control in the acute setting is going to be very important. Now, we know that many of our diabetic foot infections have ulcers involved with them. But again, it's also important for us to understand that ulcers can complicate venous and arterial vascular disease without the presence of infection. So again, our whole theme is, are these really infected? And it becomes more difficult in our diabetic patients because we know that all skin ulcers are going to become colonized with organisms. So that swabbing that ulcer is not recommended because you swab the ulcer, you're going to get bacteria, sometimes very resistant bacteria that's going to be difficult to treat, and it's going to lead you down the path of what antibiotic am I going to use for that. So similarly to the urinary tract infection, if you don't do a culture that you would not treat, don't swab an ulcer if you're not concerned that it's infected by looking at your patient and the surrounding situation of their leg. If you really feel that you have to do a culture, a needle aspiration of the ulcer margin, or of course a deep tissue culture if with a bone specimen, if you think that somebody has osteomyelitis, which you would have to be assisted with doing. But if you do have expressible purulent fluid that you push out of the tissues, you can go ahead and culture that for some guidance. But again, from this slide, I'd like you to realize that skin ulcers become colonized and that you do want to be judicious on when you're going to do a culture of that. So just like the other infections that we talked about, you do want to do a clinical evaluation and you want to categorize your infection as uninfected, mild, moderate, or severe, as you can see on the right side on this slide, with the definitions that you would follow. Your clinical evaluation, of course, the extent of the infection, is it just on their foot? Is it tracking up their leg, of course? What's the clinical bone status? By that, I mean, can you probe? Is there an ulcer? And when you probe the base of that ulcer, you hit bone that's out to the air, we assume is infected. What's their neurologic and what's their vascular examination? Is this somebody who has good circulation and has the ability to heal or not? Your laboratory evaluation, again, I have outlined here, CBC glucose. Obviously, these are the kind of patients that we want to dose antibiotics appropriately for their renal function, and they are at risk for not having appropriate or normal renal function, I should say. You can get a ESR and a CRP, and you consider that baseline. It's not that you're going to treat because it's up or down, but you're going to be able to use it as you continue to follow them. Plain X-ray of the foot is often helpful. And remember, even if it's abnormal, then you can repeat it. If it's not abnormal, you can repeat it in the future to see if it has changed. And also another reason to do a plain X-ray in terms of your patients with neuropathy is that you may see that there's a foreign body that they're not aware of. And of course, an MRI could be a backup if you're really concerned about osteomyelitis and you need to make that diagnosis. These cases, unless it's an uninfected or mild case, are usually co-managed with your other specialties. And so you'll probably be working as part of a team to address this issue for your patient. And so in the uninfected patients, the wound lacking purulence or any manifestations of inflammation, you don't need to use antibiotics and you can use local care, especially keeping ulcers moist. But in mild infections, you usually, and sometimes in moderate infections, you can use oral antibiotics with close follow-up. Again, most of these infections are polymicrobial based on the ulcer, whether you have tissue necrosis, which would have to be cleared out by your surgical helpers. Do you have malodorous drainage? Were they recently hospitalized? And so here's a list of all of the various bacteria that can cause this issue. When are you going to think about MRSA? If you've had prior antibiotic use, previous hospitalization, etc. And Pseudomonas is really not present in that many ulcers. Only about 9% of ulcers not associated with osteomyelitis. So we worry about Pseudomonas a lot, but unless we have patient who previously had it or we have osteo, we don't necessarily have to treat for that. So if we have someone who we've found by our evaluation is a mild to a moderate infection, you can treat them again with the antibiotics that I have shown here, cephalexin. You have your MRSA antibiotics, you have your aerobic gram-negative and anaerobic antibiotics. And for a mild infection, you're only treating for 1 to 2 weeks. For a moderate infection, you can treat for 2 to 4 weeks with intensive care of their ulcers. So rest, elevation, offloading, all of the things that your other specialists will help you to do. But I also want to emphasize that your antibiotics do not need to continue the entire time an ulcer or a wound is open. So again, that is another thing, it may take these several weeks to close, and then you don't want to have a patient on antibiotics that long. And the other little take-home message is you do want to follow these patients up through closing. I've had patients that look really well until that wound actually heals, and that's when you can see if there's been some residual infection, because the wound will open up again, or your patient may get very ill. And I'm going to stop with this last slide, which is an update on C. difficile. And again, as I said, this could be a whole talk of itself, but I wanted you to remember or to learn that it's no longer Clostridium difficile infection. It's now called Clostridioides difficile. There have been some great guidelines in 2021, the SHEA and IDSA guidelines. And we know that, like everything else, asymptomatic carriage of C. diff can occur. And so if we start doing C. diff testing on patients without symptoms, or on patients after we've treated them, we can get positive tests that will make us want to continue the treatment for this. So part of the treatment for C. diff, of course, is stopping unnecessary antibiotics, but doing the testing in the presence of diarrhea. Basically, any antibiotic can be associated with C. diff, and the most important thing is that there are new treatment recommendations. So the first line treatment now is fidaxomicin, 200 milligrams BID for 10 days. So that supersedes even vancomycin, and really there's no call anymore for metronidazole unless you're really in a resource restricted environment. There are issues for recurrent, or indications for treatment for recurrent disease. But again, you'd have to see the IDSA guideline. I do know fidaxomicin has been expensive in the past, but they have lobbied, and hopefully your coverage and your drug companies who supply your medications will now put it on formulary, so that would be something that's available for you. And if you have anybody who advocates or does the formulary for your patients, you probably want to have this discussion with them. So with that, I'm just going to go really quickly. What tools and references do you have? There's a CDC training on antibiotic stewardship. As I said, you have all those Be Antibiotics Aware posters that I've been showing during this presentation. The two things that I really like and encourage you: IDSA treatment guidelines, which are available at their website, and the Sanford Guide to Antimicrobial Therapy, and it's being updated to the 2024 edition. Both the treatment guidelines and the Sanford Guide can be downloaded as apps for your phone, so you can have things right at your fingertips and refer to them very easily. Antibiotic stewardship reference here, and all of these references: acute sinusitis, bronchitis, COPD, community-acquired pneumonia, UTI, and diabetic foot I've included, and C. diff. I've included articles that I reviewed and I like for your information. And thanks for listening, and hopefully we have time for questions.
Dr. Griffith-Howard, you had so much content, but you got through it. We're right at time. I know that everyone's in clinic today, so if you do need to hop off, let me just go through some really quick housekeeping items first. If you have questions, now would be the time to either use the raise your hand feature at the bottom of the screen or type them into the Q&A box. If you have to hop off and have a question, Dr. Griffith-Howard is available on our platform, so you can submit an e-consult to her with your questions as well, and she can answer them via that modality. But if you exit the screen today, you will see your CME survey pop up. Make sure to complete that. Remember, today is April 11th. This session was Antibiotic Stewardship with Dr. Saadia Griffith-Howard. So be sure to complete those portions of the survey accurately so you can get your CME certificate promptly. I don't see any questions in the Q&A box right now, so we'll give everyone a few more minutes if they have any to pop them there. And if you have to log off, we absolutely understand that you probably have patients in the waiting room getting roomed right now. So just wanted to give everyone a few more minutes to complete that. Another reminder that we will have the recording for this session posted in about 1 to 2 weeks on the MAVEN Project community portal. So if you missed the beginning, you can catch that on the recording, and the slides will be distributed via email tomorrow. I do see a question now, Dr. Griffith-Howard,
Okay.
and it is there a role for probiotics or prebiotics in preventing antibiotic complications or preventing infections in the first place by boosting the good bacteria in the gut microbiology?
All righty, thanks for the question. I am not familiar with any studies that suggest that. I think in general, anything that keeps us healthy is good, but in terms of avoiding infections, other than in the specific situations where we're doing things for transplant patients, where we're doing that kind of prophylaxis, I don't know of any studies that suggest that. That would be helpful.
Thank you. All right, any other questions from any attendees before we log off for the morning? And a big thank you to the folks at Charles River Community Health again for hosting today's
Yeah.
session. Thank you
Yeah.
to Dr. Griffith-Howard. We appreciated all the information that you had contained in those slides. Lots of really great pearls. Any last words before we log off, Dr. Griffith-Howard?
Well, no, just thanks everybody for coming early. We do these talks. I see that we had quite a few people. So have a great day in clinic. And as Meredith said, I'm available on the platform if you have any questions. The final thing that I would say, which I didn't mention, is remember some of these infections, it's nice to reach out, but you do have a time limit. So, if you do reach out on the platform, it's usually 24 hours at least before you get an answer. So keep that in mind if you're reaching out with an acute bacterial infection question.
Got it. All right. That's great words for signing off. And thank you everyone for attending. And if you have any questions, you can reach us at MAVEN Project or Dr. Griffith-Howard via the platform. Thank you so much, everyone. Have a good day.
Bye.